main trainers at Cosmetic courses. Just tell us again, Fiona, your background and what you've been.
So I was a partner in general practice and then did a foundation course with Cosmetic courses. I liked aesthetics and really made the move into aesthetics after that. I spent a summer training doing different courses and then started working for Adrian in his skin clinic. And because I had a background in training as a GP, I then naturally moved into training in aesthetics. So now most of my week is spent training, although I still do 1 day a week in clinic.
Okay, thanks. And we've got a few questions. I'm going to ask you a few questions with paper and pen. So the first thing people often ask, Fiona, is should consultations and review consultations be free of charge?
Okay, well they're two separate things. I think the initial consultation you either have to offer free of charge or have a set price for. What you can't do is be seen to incentivise them to go from the consultation to treatment by saying something like you will get your money back if you have treatment. And that really is the most important consultation because
the first one,
because you get a rapport with the patient, they decide whether they're going to come back to you, it's your chance to formulate a plan for the patient and manage their expectations. So I personally think that consultation is best being free and given a good enough time.
How long, what's a good time?
Certainly more than half an hour, I said an hour. I mean, it's going to be variable, but up to an hour of your time, I think, is time well worth spent planning their future treatments.
So I think that's a really good point. So the first time you meet a patient, spend a long time with them, because often they may not know, what treatments are appropriate. So for them,
more than that, they sometimes have an idea, but actually it's the wrong idea for what they want to achieve. So part of that consultation is re-educating them about the process of ageing or how we can best help them.
And make a plan going forward. Because the difference with surgery, so surgery is more of a one-off treatment, whereas non-surgical treatments are again and again and again. So
you want the patients to come back to you. These are going to be patients who come to you 3 or 4 times a year if you get it right. You don't want them to come once and never see them again.
So get it right first time.
But then you mentioned review consultations. Reviews in terms of following Botox treatments should definitely be free. I would see that as part of the initial treatment. Not that you have to give them extra toxin, but again, just reiterate the management of their expectations, that the results you see are what you expected, giving them additional toxin if needed, and knowing going forward how to change your treatment, but also to get good post-treatment photographs, which you won't have got with the initial consultation.
Do you try and review all the patients?
I don't. I would always see all new patients, but beyond that, I often give the expectation they can come back if they need to, but you don't want to book up your clinics with patients that aren't paying, and most shouldn't need to come back again.
And you can always check with, on the phone or by text, can't you? Great. Okay. Next question, should I always add more Botox or toxin at review?
Well, as we've touched on, no is the answer. And actually it's not a bad idea when you first start practice to audit how many patients and what doses you are giving at review. And when you re-audit the following year with experience, see if that decreases, which I've had a couple of delegates do and it's been really interesting. But no, part of the review appointment, and my bugbear is people who call it top-ups, because that gives the patient the expectation you're going to give them more, and you should only give them more if it's clinically needed, which is not going to be all the time.
And you found that your the amount of toxin, the amount of time you have to give more has gone down with time.
Definitely.
You've got more experience.
I mean, it should do, and with your experience with the patient, you should learn from that patient's anatomy how the toxin has worked and how you need to alter the plan for next time. So with the length of time you have the patient, the treatment you give them should be better.
So it's really important. So every patient is different. The anatomy of every patient is different. So you're really getting to know your patient's face and finding out what works for them. And that's what's really, really important. I think you'd agree, Fiona, to have really accurate markings and recordings of where you put the toxin on that patient.
So definitely, whether you use an online clinical system, an iPad system, some record of doses and position that you can alter next time and refer back to, definitely key.
So you're trying to find the perfect formula for that patient. So if their eyebrow went up a little bit, say, they've got a tendency to do that, so you'd modify your treatment perhaps slightly lower next time. Okay, third question. Should I treat all three areas and when should I treat a brow lift?
Yeah, I think this question's come up a lot because in foundation training you tend to train this is how we treat three upper face areas, but it doesn't mean every patient is appropriate for that. So if you have a patient who already has heavy upper eyelids or whom the benefit of raising their eyebrows outweighs the benefit of smoothing their forehead, then they would be a candidate for a brow lift, which means that we just inject two areas, the glabella and orbicularis oculi, and not treat all three.
Yes.
So I think again it's having that, looking at the patient as an individual, not thinking everyone has to have the same treatment.
Yeah, okay. Can you get a brow lift on every patient?
Not if you've treated all three areas. Because our frontalis muscle is our elevator, any toxin you put in frontalis is going to work against a brow lift. So unfortunately you can't have everything. You cannot have a completely smooth forehead and give someone a brow lift. And usually it's the more mature patient who will benefit from the brow lift because they're the ones that are at risk of ptosis, at risk of the brow dropping, if we were to over-treat frontalis.
And this is the sort of thing you've talked to in that consultation, explain to the patients.
Yeah, so you plan it with the patient, you discuss what they would be happiest with, the result they'll get from both. And if you try it on one occasion and find you need to try something next time, the nice thing about Botox is it wears off and you could try something different the following time.
Brilliant. Okay, next question. What's the best treatment for the under eye areas? I know it's a tricky area.
Other than surgery, because of course surgery could be an option here. It's a really difficult area to treat, and depending on what the clinical, the signs and symptoms are, is going to determine what you direct them towards. And sometimes it will need a combination of treatments. So we can sometimes use toxin in this area. If in an advanced course we teach this, if they've got a good snap test with good skin laxity, good skin there without any laxity, it can help reduce fine lines. We can use filler if they've got a deep tear trough under the eye, or I quite like the rejuvenating treatments to this area, so treatments that help stimulate collagen, collagenesis, which help firm, brighten, tighten. So your microneedling, your rederm, and sometimes, as I say, you might need to use a combination of those things to get the best result.
Yeah. So it is a tricky area, and you really need, I think you'd agree, you need to do the snap test where you pull the eyelid away and see if it snaps back. That tests eyelid laxity. You need to assess the fine lines, skin excess in the lower eyelid, and also the puffiness. And these all have different solutions.
Yeah.
And if you are interested in that, it's probably a really good option to come to one of our advanced courses with Fiona to look at the options in those areas. Okay, moving on. What are the common complications of lip filler?
Oh, the dreaded lip filler. I think the thing is that lips are an area that if they go wrong, they can look awful, and it's an unforgiving area to treat. The common complication obviously has to be swelling and bruising. To a greater or lesser extent, everyone has that potential because it's a very vascular area. So that can be avoided with good technique. There are some things we can also do. We can advise our patients about arnica tablets, which they can take beforehand, which there is some evidence for. We can tell them to take antihistamines to reduce the swelling. So that's got to be the commonest. Clearly the most significant is the risk of occlusion, and we are seeing increasing numbers generally, I think if you look on social media, of people who are having occlusions of lip, and that possibly reflects the number of practitioners doing it and the number of practitioners who shouldn't yet be doing it. And you need to know how to manage clinically an occlusion should it happen to one of your patients.
So this is a really important thing we probably need to talk about. So just explain briefly what an occlusion is.
So if your filler product is injected into a blood vessel, so for instance into the inferior or superior labial artery, affecting the lip, it blocks the supply of blood to that area, which can cause, if left, would cause skin breakdown, which we call necrosis. So in that event, the nice thing about hyaluronic acid fillers is we've got something that will dissolve them, so hyalase. And if you inject it where the occlusion has occurred and where you've put the filler, which might not be the same place, you can relieve the symptoms and restore blood flow to the area. There are other things you have to do as well. You consider aspirin, you consider antibiotics. So there is a management protocol, and we tend to advise our delegates to look at the ACE group guidelines, which is the Aesthetic Complications Expert Group, that have a whole set of guidelines about managing things. Yeah,
so briefly, Fiona, so if you're injecting, what techniques can you use to reduce the risk of occlusion?
Specific to lip, it's about selecting the right product, not injecting too much in any one area, so overfilling or a bolus. Technique, we tend to prefer a bolus technique where you can aspirate and inject in one place.
So then you know you're not in a blood vessel.
You can't be 100%, but it can help. It is a better technique at avoiding that than doing a linear thread. So it is about those things, and injecting in the right plane, in the right area, which is why it comes with experience and why we tend to say you need to be a more advanced practitioner to inject lips. And then knowing how to manage it, were it to happen.
So the key things to avoiding it are, bolus techniques, knowing your anatomy really well, and experience, and avoiding the danger areas. Signs of an occlusion, if you think you've got one?
So signs and symptoms should be put together. So pallor, it can be a reticular rash.
What's a reticular rash?
It's a red spidery rash across the area. It can look a bluish colour, a bit like a bruise, usually well demarcated. Reduced capillary refill time.
What's capillary refill time?
It's when you press the skin and release it, the blood flow should return within 2 seconds. If it doesn't, it's a sign that blood flow is being impaired. Pain, but this is one where I'd say don't forget you've just numbed the patient and injected anaesthetic. So I'd always say, if in doubt, keep the patient with you. Don't send them home, because it will become apparent. And there's evidence that if you relieve an occlusion or you use the hyalase within 4 hours, you will avoid necrosis. So you don't have to rush within seconds to your emergency box. You can wait, and the signs and symptoms will develop.
But don't let them go home, I think is the key. So if you're injecting, anything abnormal happens, if you see white blanching, if you see a change, the patient experiences any severe pain, the first thing to do is stop, and then review the situation and see how they get on. If they do have any of those, if they definitely do have an occlusion, how do you manage it?
I would be giving them aspirin. So we stop injecting, as you said, we can massage. We can put heat on the area, and any of those things might return blood flow. But if it doesn't, we would be getting our hyalase from our emergency kits. We wouldn't forget to take photographs. So on my consent form for hyalase, I write photographs in red at the top, because in the panic you might forget something like that. So a record of what you've done is really important. We'd get the patient to consent to the hyalase, again important. And then we'd be mixing our hyalase and injecting it where you see the occlusion and where you place the filler, which may be 2 separate places.
So the filler gets into a blood vessel, it can travel within the blood vessel to a separate area. So it's not just where you inject it, isn't necessarily, it's where you see the symptoms, because you need to dissolve that hyalase within the blood vessel to re-establish blood flow. And in any type of tissue that does have reduced blood flow, it can recover. There's a recovery time if blood flow is restored within, say, 4 to 6 hours. It depends. Muscle is is more critical. It needs to be done earlier, and skin a little bit longer. So different tissues are different amounts, aren't they?
So you would inject your hyalase. You might give aspirin as well.
Dose of aspirin?
300 milligrams, and then you would tell the patient to take 75 milligrams a day for a few days. And then again, you don't send them home, because the half-life of the hyalase, once injected, can be under an hour. You might find you have to re-inject hyalase an hour later. So they're going to be with you for 2 or 3 hours before you feel that satisfied to send them home.
So I think the key is try and avoid it, know your anatomy, advanced techniques, early recognition, and prompt treatment. Okay. Next question. I think we've talked about complications of fillers. Can I do lip filler if they have a lip piercing?
I mean, the answer is you can, but because filler in lip particularly can swell, ideally they would remove their piercing before you treat them. If they don't want to, and I've had a couple of patients who that's difficult, they just have to be aware that if their lips start to swell, they are going to be able to remove their piercing.
Yes. Yeah. Okay, brilliant, Fiona, thank you. If I use Hyalase, we've talked a little bit about this. And everyone should have the protocol. We have the protocol.
Yeah, and you can join the ACE group for a fairly minimal cost and have access to all of their guidelines of managing different things.
How do people find the ACE group?
They can Google it, so if you just Google ACE group, it will come up with who you need to contact them. And some of the guidelines are just available on the web. Their guideline use of Hyalase can be found. Anyone who comes on our courses, we do provide copies of those guidelines.
And does everyone need Hyalase with them if they're injecting fillers?
I think it's negligent not to have Hyalase if you're going to do filler treatment, because you've got to be able to manage all your complications.
And refrigerated Hyalase, how does that?
Well, you don't have to keep it in the fridge. It's not until it's reconstituted.
Yes.
You can keep your emergency box in the fridge, but just stored in a cupboard at normal temperature.
So if you are doing fillers, we would strongly recommend that you do have the Hyalase available.
Yeah.
Okay, how can I best treat fine lines across the face, Fiona?
This is a different. I think this question comes up because lots of delegates have the impression when they come that lines are to be treated with filler. And certainly traditionally that was the case. Any static lines, fine or otherwise, could be filled. But the problem with those across the cheeks that if you do that, you just bulk up the face by adding volume. And the move really now with filler is to use it more as a volumizer for structure in the face, and for the texture of the skin you're looking more at the rejuvenating treatments. So again, any of the treatments that stimulate collagen and elastin. So your microneedling, your PRP, which is platelet-rich plasma, your Rederm, your Profilo, all of these rejuvenating treatments. And to a certain extent, if you've got a patient in need of rejuvenation, you would do that perhaps before you consider toxin and filler to get the best result. So again, it's just being mindful that it isn't all about filler and toxin. You have to have a broader approach to how to treat people.
Brilliant. Okay, Fiona, so moving on to training, we'll talk a little bit about training. So first question is, how much can we cover in a day of training? There's a limit how much you can take in a day, isn't there?
And I think you have to be realistic. Whatever training provider you go to, what you can provide in a day is going to just be the start of your aesthetic journey. So you should be able to get theoretical information about Botox and filler if that's the course you're on. You should have been given pre-course reading perhaps as well. You should be able to have practical hands-on experience of both toxin and filler, but your knowledge is not going to be all-encompassing when you leave after a day. So you may feel confident to go and start doing upper face Botox, but certainly for filler, we encourage people to come back for follow-on or one-to-one training because a day is going to be limited.
Yes. So the foundation course is basically a taster. Upper face Botox, is relatively straightforward, but filler more complicated, and you will do more training.
So you'll have experience of both, but it can just be a snapshot, and we would expect you, as with any medical profession, to have to come back and do more training.
Okay. What support is available after my training?
Well, I think that's where, as cosmetic courses, we sort of hold our own really, because we do offer a support to all our delegates. They can phone, email the Ask at Cosmetic Courses email address, and there'll always be someone, myself or the other lead trainer, will answer clinical queries. I think that's a really important thing, because you feel you've done a course, you might be practicing on your own, you're not in a team, unless you're working in a clinic, you haven't got anyone to ask. So we do offer that service.
Because it is, I think that's a really good point that Fiona's made. So, clinicians are normally in a team, and when you work in the non-surgical, start off, often you are alone, and many of our delegates feel they would like more support, and that is something that's great in cosmetic courses. So if you've been on a course, if you've got any queries, please get in contact anytime. Okay, so I've completed an FDN course, foundation course. what would my best options be to get into lip treatments?
Oh, lip treatments. And this is, again, reflecting how popular lip treatments are and that people want to be doing them straight away. We would generally say if you are a new practitioner and haven't had much experience with other basic filling techniques, you could come on a one-to-one, so a bespoke training session where the level you are currently at can then be addressed. You'd be on your own with a trainer, spending 4 hours, have 4 patients, and at the end of that session I would hope be safe and competent in treating lips. If you're more experienced and have been doing basic filler already, or have been doing lip for some time and want to learn some new hints and tips, then we have a lip masterclass, which is a day, but it's a small group. So you'll see many more treatments, but you won't do as many yourself. You might do 2 patients yourself, but watch.
But you see a big variety.
But see a variety.
So people starting dermal fillers treatment, what would you suggest they start on and build up to? What are the first treatments?
This is different because we do filler around the mouth tends to be considered basic filler, and that's because how it's administered as a linear thread is a more basic technique. Although ironically, the nasolabial fold can be one of the at-risk danger areas. So how we teach it is important, which is a deep bolus at the top of the fold. So nasolabial lines, mouth corners, even lateral cheek, which is the foundation of cheek filler, I would consider basic and can be covered on our foundation. And I'd expect people to perhaps feel happy to go out and practice those things, if not after foundation, after a one-to-one training session. And then when they're comfortable with those, come back to do perhaps some lip training with us.
So build up gradually. Build up their expertise. Okay, why should I be confident in the basics before moving on to advanced procedures?
I mean, it's kind of logical. You want to be good at what you do, and that does require you having a solid foundation in the basics and giving your patients good results. You know, they're paying a lot of money for treatments to be what they want, and it's also very disheartening if you provide a treatment where someone isn't happy. So I think if you want to be the best you can, you want to do that in a logical way and make sure you're really comfortable doing certain treatments before you build up to something more difficult and do it well. And then your patients will come back, they'll tell other people, and you'll ultimately be more successful.
Absolutely. So investing in training is really one of the best investments you can make.
So,
And all our trainers, you still, Mel, go to, and Ruth go to regular updates, don't you?
Well, everyone needs to. I still do annual appraisals with 50 hours of CPD. So we all need to do regular training and learn new things.
Great. Okay. So moving on, how can I train in cannulas, Fiona?
Okay, so we like using cannulas because they can be one technique we use that's safer sometimes than needles, but you can't jump straight from doing nothing necessarily to using them. So often in our one-to-ones, if judged appropriate for the patient and the delegate, we'll introduce the use of cannula. And on our more advanced courses, so certainly doing cheek filler or our contouring course, we would expect to use cannula or the lip masterclass. Or someone, if they specifically want to come and do a session with cannula, they can ask to do a one-to-one training session in cannula where we try and provide a range of patients and get them up and running with that. So again, another advantage I think we have is we can tailor-make something to your requirements if you need.
And cannula is a good thing for people to be able to have in your sort of armamentarium, do you think, Fiona?
Definitely, because as I said, they can be safer because they're blunt, so they should bend around blood vessels. So I tend to use them in areas where I want to be safer, where I know there's at-risk areas such as the infraorbital foramen, or for effect, if I want to leave a smooth sheet of filler in an area, or to help stimulate collagen, because a cannula can do that as well, I might choose a cannula. It can reduce bruising, so in areas that bruise badly, such as the marionette lines or chin, the cannula will reduce bruising for the patient by minimising the number of access points. So it's another tool that's well worth knowing how to use.
Absolutely. Okay, brilliant, Fiona. As a doctor, if I leave the NHS, how do I get appraised and revalidated?
Well, if you join the British College of Aesthetic Medicine, which I'd highly recommend, so they now accept doctors and dentists, they have a responsible officer, so that's the route I take for appraisal. The difference is you do have to self-fund it because it's within the private system, but the process is exactly the same as if you're in the NHS. Or you can work for a clinical group that they may themselves have a responsible officer, which you'd have to find out about. But if not, ECAM would be the route that you have to follow.
So it's a similar process to if you were in any other speciality. Okay. How can I get exposure to watching procedures or shadowing practitioners?
I think that's very difficult, and we get asked this a lot. Because it's a private industry, people are reluctant to let new delegates follow them, because they're worried they're set up down the road and be competition. And we do run an observation day, and originally that was for our level 7 delegates who are required to observe 10 Botox treatments and 10 filler treatments, but it's become more popular with people who just want to observe lots of treatments, and actually it's just a really good way of getting exposure to a range of treatments.
And understanding how a clinic works.
So through training, I would say coming on an observation day or finding someone who is happy for you to shadow them, but that can be difficult in the industry.
Okay. What should I look forward to? What should I look for in a training provider if you are thinking of having going into the industry? What are the key things someone should look at, Fiona?
Because there are lots of training providers.
That's right.
And I think the difficulty is that anyone can have a very slick website and rent a room at an address that looks appealing, but not necessarily provide a quality of training. So I think you need to look at how long the training company's been established. When was it established and by whom, and what's their background? Who are the lead trainers? And sometimes this, asking these questions. How much time have they spent in aesthetics? Because the reality is they may have only been doing it for a year. Do they still work in other capacities, or are they solely doing aesthetics? How many delegates do they train? What sort of courses do they run? What support will be there for you afterwards? So asking those questions, not just looking on their websites, may be worth doing. I mean, what do you think? You've been in doing this.
Have I? Well, I would agree with that. So, I mean, the industry's got so much bigger, hasn't it, Fiona? So when we started cosmetic courses back in 2001, and most of the, if you wanted treatment, mostly you went to Harley Street or around the major cities, and very few people had treatments, and the treatments weren't so advanced. So now people are having treatments more locally, and the treatments are much, much better, and there's more practitioners doing it. So the whole speciality has really come on leaps and bounds, hasn't it, in the last sort of 15 years.
Yeah, it has, but we want to ensure quality, and I think the problem at the moment is the expansion of numbers hasn't necessarily meant an expansion of quality practitioners, and that comes down, I think, to the training, that anyone can be a training provider. So I think it's really important, and to pick the right training provider, to try different training providers sometimes. We do get delegates who have been elsewhere, but make sure that it's going to offer you what you want out of the course you're doing.
To make you the best you possibly can be. Absolutely. And last question, what new courses have we added recently, Fiona?
I think our most recent addition has been the contouring course, looking at trends in treatments, defining chins and jaw lines, in addition to lifting from the mid-face and cheek, is popular for patients of all ages. So we get our older ladies with lower face laxity who benefit from lift and contouring, as well as younger patients who want that definition. So we've added that course. It's proving very popular. We obviously do use cannula and needle on the course. It's a day's course, and we get a lot of patients to do it, to use.
So how many people will be on the course?
It's a small group course, so up to 3, and we have a lecture at the beginning of the day to look at the theory. We like the Allergan code system, so we look at the codes, we look at anatomy, and then we have a day of patients requiring, often we will treat as the patient as is needed, so we have to assess the patient, and then you'll have lots of hands-on experience in doing that.
And a great course, what sort of person would it be suitable for, what level?
Probably after you've done foundation and maybe a basic one-to-one, that you've done some filler yourself, but you don't have to be at an advanced level. It can fit in instead of our intermediate advanced course, which might be more where you learn lower face Botox, hyperhidrosis, bit of cheek and lip. You might decide to do the contouring course instead. So there's a whole range of courses and what route you choose to navigate through, but the contouring course is our newest course.
Okay. So before we finish, Fiona, any last messages to anyone either considering entering the industry? First of all, anyone considering the industry, is it a good industry to be in, do you think?
I think it is a good time to come into it. It is expanding. There are changes afoot. But it can be flexible with the rest of your working practice. There are lots of avenues within it you can pursue, whether that's injectables or rejuvenating. There's lots of business opportunities, teaching opportunities. So I would definitely encourage someone who's willing to put in the work and the training to look at it and consider it.
Brilliant. Well, thank you very much for joining me today, Fiona.
You're welcome.
And have a great weekend.
Thank you.